I'm Anne Graham. I am an osteosarcoma survivor. I was diagnosed at age 43 and treated in the Pediatric Cancer Center at Sloan Kettering by Dr. Myers, who I haven't seen, but I hope he's here. Anyway, so I survived osteosarcoma, hope that's wood, and because I was in, thank you. Thank you, but really thank you, because it's great science, it's the great dedication and work of people like you who get us to the place of survivorship. So I started MIB Agents because I survived and because while I was in treatment in the pediatric center at age 43, I was inspired by everything. I was inspired by the kids that I was treated with who had way more courage, way more hope, way more everything lovely and that I would aspire to be as a human on this earth, was all inspired by these kids that I was treated with who just went through it so much better than I did. So today, MIB Agents funds osteosarcoma-specific research. We have patient programs. We have educational programs for the entire osteosarcoma community, including professionals. And we also do legislative work. So one of our, really our superpower at MIB Agents is our Junior Advisory Board. This is made up, this year we have 25 Junior Advisory Board members. They are in treatment. We have a couple in hospice care. They are survivors and siblings of kids who passed. They inform everything we do at MIB, and they are rock stars on Capitol Hill. They do legislative work without adults in the room, and they crush it. So I just want to introduce three of our Junior Advisory Board members who are here at ASCO. They'll be in our booth at the conference, and just wanted you to meet them, and also thank SARC for helping sponsor them to be here. So with that, we'll start with Sona.
Hi, everyone. My name is Sona. I was treated at Memorial Sloan Kettering. I had osteosarcoma in my left scapula, and I'm about 5 years NED now. Yes. Thank you. I also just graduated from Tufts University with a degree in biology and a minor in physics. And and in the fall, I'll be starting at Harvard Medical School, and I'm very interested. Thanks for all the claps. And I'm very interested in oncology, and part of my reasoning is because of what I went through and also being able to learn from all of you. And so, thank you.
Hi, I'm Samantha Ulloa. I go by Sammy. I'm from Southern California. I was treated at Loma Linda Children's Hospital. I was diagnosed with osteosarcoma in my right proximal tibia in August of 2022 at the age of 19. I'm currently about 2 years NED. I am currently... I'm pursuing a degree in psychology with the goal of becoming a child life specialist, and I volunteer with MIB Agents. I'm currently the president of their Junior Advisory Board, and I co-host their podcast called Osteo.
Hi, my name is Andrew Basaga. I was diagnosed with osteosarcoma in my right proximal femur, 7 years NED. Thank you. I was treated at Advocate Children's, so not too far from here. But now I currently attend Creighton University, majoring biology, and then to go to medical school. So we'll see. Fingers crossed.
This is just, they're just the most amazing people, and this is why I think we all do what we do, but this is why MIB agents exist to make it better. And I have to say, I think something that came through, well, every time these young adults speak, is there's a saying that goes, when you have childhood cancer, it greatly increases your odds of becoming a doctor. So that plays out here. And Kurt Weiss can probably attest to that as well. There he is. Okay, so thank you very much to SARC for having us. I'm also a board member, by the way, so I'm delighted to have you all here, and thank you to our sponsors for making this all possible. So if I'm allowed to introduce Kurt Weiss, Dr. Weiss is an amazing human being, in addition to being an orthopedic oncologist, surgeon, runs the musculoskeletal tumor lab at UPMC, and is an osteosarcoma survivor, and is a regular mentor to our junior advisory board. So that, Dr. Weiss, over to you. Thank you.
Hey everybody, good morning. I kind of wish my mom were here to hear that. Good morning. Thank you for sticking it out despite the break. I'd like to invite all the panelists to the podium. My name's Kurt. I'm at the University of Pittsburgh, and as Anne so kindly said, I'm a musculoskeletal oncology surgeon, osteosarcoma survivor, struggling physician scientist. And today we're going to talk about what we should do for sarcoma patients with oligometastatic pulmonary disease. And I'd like to thank all my panelists. You have gift bags with Pittsburgh Cure Sarcoma swag. I have one for Dr. Pollack also, and Mr. Young. So thank you. Now, where do I? Okay, so my first disclosure is what was given away by Anne. I'm a very selfish person, and the reason why I'm selfish is because I myself am a survivor of metastatic. Mike Moore? Okay. I myself am a survivor of metastatic osteosarcoma and had 2 open thoracic procedures. My main area of research is trying to understand sarcoma metastatic potential. So when Mr. Young and Dr. Fletcher say, hey, you know, what should we talk about with the smartest sarcoma people on planet Earth for an hour? I know what I want to talk about. So I hope I can convince you that this is a good use of your time for the next hour. Our sort of outline is we're going to introduce the question. I'm going to do a very, very, very truncated literature review, introduce our amazing panel. Our panelists are going to give us their sort of 2 cents, their thoughts as they approach the problem of oligometastatic pulmonary disease, and then we're going to talk about it. I do hope that there is time at the end for us to discuss where we ought to go from here in terms of what questions should we be asking as a community of scientists. So here's our question. What should our approach be for sarcoma patients with oligometastatic pulmonary disease? And despite, we've heard it several times today already, despite the ubiquity of this problem and its prognostic importance, I do not sense that we have consensus about what to do with these patients, even within our MDT at the University of Pittsburgh. We tend to be fairly aggressive about sending our patients to thoracic surgery for evaluation, but we have also used SBRT in some patients, and Dr. Burgess and Dr. Nasev are here. Sometimes they will advocate for leaving a lesion that is easily accessible so that they have a barometer to judge their systemic treatment. And even though I'm a dumb surgeon, that makes sense to me. So, what are we to do? Well, here, one of my favorite expressions is orthopedic surgeons tend to use the literature much like a drunk uses a lamppost, more for support than for illumination. But That said, I wonder if we don't all do that sometimes. Here is an cited paper from our colleagues in Italy where they looked at their osteosarcoma experience. So let's start with something where we maybe do have some consensus, and that's osteosarcoma. So they looked at a 20-year period, and in the second half of that period, they were quite aggressive about sending people for metastasectomy, and there was a greater survival. This is a really cool study that I just found in preparing for this from our colleagues in China, who also looked at about a 14-year period. They had a lot of patients that had metastatic disease and several who were deemed to be operative. And those who chose surgery rather than and chemotherapy rather than just chemotherapy did better. Leading Crotu, I apologize for the pronunciation, in 2019 to conclude that there is copious evidence in osteosarcoma that resection of primary and metastatic disease is essential for long-term survival. Now that's a little bit strong, but I think we can agree that most of the people in the room, most of the time, would send your osteosarcoma patients to thoracic surgery for pulmonary metastases. But as we've heard so many times already today, there are questions, and more questions. Can we extrapolate these data to other pediatric, adult, young, adolescent, and adult sarcomas? What's the role of SBRT and other ablative things that our interventional radiology colleagues are experimenting with? When should we just watch them and use them as a barometer for our systemic treatment? And should we be doing this at all? If you take the extreme contrary argument, this is a paper that Robin sent me. I'm not going to read the whole thing, but the authors conclude that we don't even know what oligometastatic means. There are flaws in the observational evidence, which is not prospective. And these authors conclude that it is unethical to proceed without a prospective trial. Now, I've thought for a long time that it would be unethical to do a prospective trial, but I don't agree with a lot of what's on this slide, but I don't know that I can refute all of it. So, in order to try to make some sense of these difficult questions for these difficult patients who really need us, you would have to assemble an elite team of sarcomatologists, thank you, Dr. Randall, for that awesome word, to demonstrate how they approach this problem from a multidisciplinary standpoint and what questions we might ask to seek our truths. But where, oh where, would we find such a team? Well, it turns out the answer is Chicago. Now, these are not the Marvel Avengers, these are the Sarc Avengers, and let me introduce them. If you've been to CTOS in the past few years, you have had the pleasure of hearing Dr. Betty from the Medical College of Wisconsin, who's doing really extraordinary work in radiation oncology for our sarcoma patients. And I came across this paper, and I certainly hope that she's going to teach us a little bit more about this innovative work. Dr. Gupta, my old friend from the University of Toronto, although only one of us actually looks older, she is sort of the authority in adolescent young adult oncology in Canada. She directs CanSarc dual appointments at Sick Kids and down the road at Princess Margaret, which is super impressive, and also, fortunately for us, our CTOS treasurer. Speaking of the CTOS presidential line, Dr. Jones from the Royal Marsden, who has more letters after his name than in his name, we all know what a brilliant and generous guy Robin is, and he has a very unique perspective, having been at the Hutch and now at the Royal Marsden. So he has seen sort of on both sides of the Atlantic, and very luckily for us is our CTOS vice president. Thank you for making the trip, Robin. When we started putting this team together, I thought, we really need to have a thoracic surgeon. This whole discussion is woefully inadequate without a thoracic surgeon. So I reached out to Seth. There's a gift bag for you too, buddy. And who is someone you work with there at Northwestern that would be willing to talk to us. And he put me in touch with Dr. Kim, who has been nothing but gracious with his time. He is expert at minimally invasive thoracic surgery. And thank you for hanging out with us sarcomatologists for the morning, Dr. Kim. We really appreciate you. And finally, Dr. Wilkie, who's coming to us from the University of Colorado. If there is a more innovative, fearless, energetic sarcoma clinical trialist in the room, I don't know who it would be. Her focus is with immunotherapy and TME, and is my very good friend also. So I challenged the panel to come up with some questions that we ought to be asking, so I will lead off and say maybe these are some things we should think about. Should we be constructing a succinct and not onerous set of data fields that we all can look at our institutions in order to make some sense out of what we're doing and why and how it does? Should we be talking about a prospective randomized controlled trial for surgery versus SBRT? I think Dr. Betty probably has something to say about that. How can we incorporate patient-reported outcomes data, input from our advocacy groups, and complications? You know, there's no free lunch here. I had complications from my thoracic surgery. I would argue that it was probably worth it, but you don't get something for nothing. Now, this is an extreme example, obviously. I don't know that we would be sending this patient to Dr. Kim, but we all have patients like this. The impressive thing about this axial CT is not the Ewing sarcoma on the inner table of this guy's left scapula, which you probably didn't even see. I got a good answer for that. I can take that out. In fact, I did take that out. I got a good answer for that. I don't have a good answer for what's in his chest, and we must do better at that. So thank you, Sark. Our amazing panelists, again, Dr. Pollack, Sam, Northwestern for being our hosts, all of you, and let's get to it. Thank you. Awesome. I love it. So good.
So for those of you that don't know what Dr. Weiss gifted, one of the things he gifted us was this terrible towel, which is, some of you may know at the Pittsburgh Steelers game, this is what they annoyingly swing around the whole time. And as you may know, the Pittsburgh Steelers are trying to lure Aaron Rodgers to your team. And as I can just say for all Packer fans, you can have him. And good luck. We'll see how it turns out. But that's not the topic of my talk today. My topic of the talk is what Dr. Weiss so eloquently introduced regarding oligometastatic disease, or any metastatic disease, particularly in the pulmonary region for soft tissue sarcomas. So I'm going to start off with a brief case. It's a 45-year-old male, had pain and swelling in the left distal femur. Path revealed a grade 2 chondrosarcoma, and staging scans just had some indeterminate pulmonary nodules. So the treatment course outlined here, he had a limb salvage surgery with a distal femur endoprosthetic reconstruction in December of 2011. About a year later, recurred locally and had an AKA of the left leg. And then about 6-ish months later, had again another local recurrence and was managed with a left hip disarticulation. So he had then CT scans, and from 2013 to 2015 really was doing pretty well. Did have some slowly growing right lung nodules, and in May 2015, it grew enough to the recommendation that he should have a VATS procedure. He had 5 lesions, all were removed, all were positive for metastatic chondrosarcoma. About 6-ish months later, again, new left pulmonary nodules, for which he underwent a wedge resection of 2 lung nodules, which were the only 2. And again, metastatic chondrosarcoma was what the pathology was. And then again, about 3.5-ish years later, 4 nodules on the left lung, 2 in the right. All 4 on the left were removed via VATS. and metastatic chondrosarcoma was the path. And so all this patient had left was the 2 right lung nodules, no other disease elsewhere. And you can see on the coronal view the 2 lung lesions. I don't know if there's a pointer here. Oh, no, okay. So the 2 lung lesions on the right side on the coronal view that you can see. And so the question that I have for the panel and even for the audience is, what management would you recommend for these right lung nodules? Knowing the patient, their history, their disease-free interval, I would love to hear from you what you would recommend in this setting with the 2 right lung nodules. Yeah.
Of course, I'm going to choose B, surgery.
Surgery. Surprising.
Maybe a clinical trial if they're a candidate, but other than that, chemo is not typically a great option for chondro.
Yeah.
So we would be thrilled to ship this guy over to
Yeah.
our surgery colleagues.
Yeah, I am, just to be contrary, I would say observation for a period of time and just gauge the further tempo of the disease.
I would agree with observation for exactly that reason, just to see what's going to happen in the next 3 months.
Yeah. All great choices, and all I don't think are necessarily incorrect. I mean, I think if you present this case to 5 different tumor boards, you'll get 5 different answers. What we chose in this setting in our multidisciplinary group was to employ SBRT, or stereotactic radiation therapy. And so that will be what I'll go over in the next few slides. We know, as Dr. Weiss had mentioned, the pulmonary area is the most common site of metastasis in sarcoma, typically managed by metastectomy. If chemotherapy is an option, it's more widespread. Certainly chemotherapy is employed. And there is abundant data for SBRT to the lung in many histologies, which have really great rates of 2-year local control, over 80% certainly. But the data in sarcomas is not as robust. And so the question is, can we extrapolate it from the more radiosensitive histology data? Was there going to be a benefit? And there have been a handful of studies that have looked at this where we have employed SBRT just strictly for sarcoma subtypes. And what the takeaway from this is that really there's been excellent rates of local control on par with the more radiosensitive histologies that we see and often treat with SBRT, onwards up to 96% local control at 2 years with very little toxicity. So in this case, as I mentioned, we did recommend SBRT. This was my plan. We chose to treat 50 gray in 5 fractions. So these are the axial views. And this is the coronal view. The lesions were so close to each other, we treated them in one kind of larger field, but employed an SBRT approach. One thing to notice is that even though 50 gray was our coverage or our prescription dose, we really wanted to heat up the core and heat up the tumors itself. So the tumors itself actually got 60 gray in the 5 fractions. So an escalated dose, which we really tried to do in the SBRT setting. There have been also SBRT studies in the non-pulmonary setting, and these 2 studies have shown that just like in the lung, there's excellent rates of local control. And so I think SBRT can be appropriate in various settings, and I just put up a scenario or different scenarios, and again, asking our panel, when would you consider using SBRT in this setting of a 90-year-old male with a history of pleomorphic sarcoma, solitary lung lesion, it measures 6 cm but hasn't been biopsied? Would you do it in a 56-year-old female with leiomyosarcoma and widespread METs? A 34-year-old male with oligometastatic synovial sarcoma with 2 lung METs, very low burden, so less than 2 centimeters in the right lobe, or a 60-year-old female with oligoprogressive disease, metastatic angiosarcoma, again, very low volume and low burden, less than 2 centimeter disease, but does also have a newly diagnosed brain METs. So just anyone in the panel that have recommendations, or are there scenarios that none of these you would recommend SBRT necessarily?
why this is not working. Sorry. So I'm not sure, maybe there would be more additional details here, but I think the take home for us at least is you want to have systemic control. And so, or the patient needs to be symptomatic from one of these lesions or something that you're worried about, particular lesion, to go after it. Because like, for example, patient B, you're not going to fix the underlying problem with focused radiation. On the other hand, a 90-year-old might not be a good surgical candidate. And if that's really it, and the rest of his disease is controlled, it makes sense.
I'd agree with that. I think the context is really important in terms of time to development of metastatic disease. In terms of the precise anatomic location of the tumours as well, one of the cases I am going to briefly present is a patient with really indolent leiomyosarcoma on observation for 3.5 years, and eventually the tumour started to grow, and if it would grow further, then clearly problems would arise. So I think the context in terms of time to development of metastatic disease, anatomic position, are really, really important in terms of making the decision.
Yeah, 100% agree. Taking all the factors into consideration is very important. And that's what we'll learn with our presenters today. And next up is Dr. Wilkie. Dr. Weiss did ask us to think about 1 to 3 research questions we would try and employ. And I know Dr. Wilkie will touch on this, but for me, we do know that SBRT and higher doses per fraction elicit an immune response. And is there a way we can augment that immune response with immunotherapy and not just treat locally, but also help from a distant control perspective? And so with that, I'd like to introduce Dr. Wilkie. Oh, Dr. Gupta. Oh, I'm sorry, Dr. Gupta.
Dr. Gupta.
Yeah, thank you.
Hello, Abha Gupta from Toronto. Thanks, Kurt and the organizers for having us come up here. So I wanted to, we asked Kurt, which sarcomas are you focusing on? He said, make it interesting and include everything. And so I'm going to focus a little bit on the small round blue cell tumors and thinking more about, what about those micrometastases? We feel, when this nodule goes away with chemotherapy, this is a kid with Ewing, a young adult with Ewing sarcoma, and his solitary lung met went away. You kind of feel good, but you also kind of feel really stressed about this, because what about all of those other micrometastases that you can't see? What are you supposed to do? So we know that whether or not you give patients whole lung radiation or you take them to high-dose therapy with stem cell rescue, there's a huge number of patients that still fail with recurrent and metastatic disease. So clearly neither of these two modalities is sufficient to cure those micrometastatic lesions. It's kind of interesting, this great survey was done a few years ago asking, amongst the different disciplines, who would actually offer whole lung radiation as a tool to help think about intervening on these micrometastases. And it's always the pediatric oncologists who are like, yeah, let's do it, let's do whole lung radiation, compared to medical oncology colleagues. I think I probably quote this paper the most often whenever I'm speaking to trainees about what whole lung radiation might or might not do. What is whole lung radiation? Maybe 10 to 15 gray to the entire lung, just enough to induce some mutations in our sarcoma. And Dr. Whelan and his team, published this great review that really kind of suggested that there's probably not really a role for this particular modality in patients with metastatic sarcoma. Most recently, actually, there was a report published from the Children's Oncology Group with another small round blue cell tumor, and that's rhabdomyosarcoma, where they looked at numerous trials collated and compared the outcome of patients who received whole lung radiation to those who did not receive whole lung radiation, even though all patients were intended to receive whole lung radiation as prescribed by the study. And the patients who received whole lung radiation had a better survival than patients who did not. However, if you can see on multivariate analysis, whole lung radiation did not actually contribute to this survival benefit. So really all we are doing with this intervention, and maybe many others, is selecting for the patients who would probably do okay anyways with your primary modality of therapy, which in smaller and blue cell tumors is chemotherapy. So Charles Catton, which many of you know, is one of my favorite mentors in Toronto, and he, always challenges me in clinic, and he's like, when I ask him actually to do SBRT or something on one of my patients, he's like, are we really keeping the patient occupied while the natural history of the disease takes its course? So, I guess my feeling is that for any one of us who are considering whole lung radiation for our patients with at least smaller and blue cell tumors, you should think twice. I think now with modern techniques, the dose of radiation therapy to breast tissue and heart tissue has decreased. So maybe we don't have to think so much about the long-term toxicity of rates of breast cancer and cardiotoxicity. But I still think that when it comes to thinking about lung metastases and sarcoma, maybe less is more. Thanks.
So thanks, Kurt, for that great introduction, and thanks to the SARC team for asking me. I've really not got much to say. I think I don't have a clear answer to the question on how best to treat oligometastatic disease, and in a way, I don't really have an answer to the question on how best to investigate this and to evaluate this. I think Kurt is right in terms of collecting data, particularly data on patient-reported outcomes following lung surgery in particular, because most of the retrospective studies that have been published give no indication regarding quality of life after fairly invasive thoracic surgery. I think the other thing that we don't really have a handle on is the biology of the disease, in terms of why some patients with metastatic leiomyosarcoma, metastatic osteosarcoma do so well after surgery for metastases and others don't. And I think if there is a way to sort of tease that out and to identify patients who are going to do well following surgery, then obviously that would be absolutely amazing. I tend to be more on the Tom Treasure side of the argument and would potentially carry on with surveillance for patients with solitary or oligometastatic disease if they're asymptomatic and the tempo of the disease is slow. And I've got two cases just to highlight the dilemma, in a way, on how best to treat patients. So the first one is a long-standing patient with metastatic leiomyosarcoma, 51-year-old, who underwent surgery at an outside institution in November of 2009, and she had a resection of a left pelvic sidewall tumor. It's reported as ER and PGR negative. The outside institution mentioned that the margins were close, and she went on to receive adjuvant radiation at that facility. She was then referred to our hospital and was on surveillance, and in February 2014 had a resection of an isolated recurrence beneath the right lateral abdominal wall. And eventually, as I mentioned, she went on to have surgery for a lung metastases in March of last year, but she'd been on surveillance for this lung metastasis from early 2020. This is a scan from 2021, and it shows how difficult it was really to see that tumor at that time. But eventually, after a lot of discussion with the thoracic surgeon and with the patient herself, we decided to go for surgery based on the position of that tumor. And if it would grow more, then it's obviously going to cause problems. She underwent surgery, but basically has had a lot of post-operative pain after the procedure. And again, highlighting Kurt's point regarding any further studies on resection of metastatic disease should really incorporate quality of life measures, but also try and incorporate translational studies looking at the biology of these tumors. And just another case of metastatic leiomyosarcoma, 67-year-old, again, underwent surgery at an outside hospital in October 2014, total abdominal hysterectomy. It was a leiomyosarcoma, ER and PR positive. At the same time, staging investigations showed a left hilar mass, and she underwent resection of this left hilar mass in December of the same year after a short period of surveillance. And again, that was metastatic leiomyosarcoma, but ER negative in the metastasis. And again, the reason that we decided to go for surgery in this case was the challenging anatomic location of this tumor. And that's a last follow-up scan from February of last year. So as I say, I don't really have an answer to this question, and I don't know of a really definitive way to actually answer the question, but welcome the discussion. So I've been very brief. Thank you.
Thank you very much. So I didn't prepare any slides, nor got any fancy video of my operations. However, I will try to do my best to defend surgery. So I realized that Dr. Weiss had a metastectomy, and the case that was presented, those patients had a thoracotomy. Dr. Weiss had a sternotomy and thoracotomy. The question for me is, in modern day right now, of our patients, how many patients actually do undergo an actual thoracotomy for something like this? Just like medical oncology, radiation oncology, surgery evolved too, right? So now in the days of robotics, where we have a high definition CT scan where we're able to detect 3-millimeter lung nodules, we're doing robotic surgery. We're doing robotic bronchoscopy to isolate these lung nodules where we're trying to preserve as much of lung function as possible. Majority of my patients who undergo metastectomy, and Seth here could attest to that, a lot of patients will go home in the same day or next day, even after we're resecting 7 or 8 or 9 lung nodules at the same time. So now I do agree with you that I'm not the proponent to operate on everybody, but I do want to give you some sense as what I'm thinking about when I'm thinking about operation for patients. So obviously, whenever I'm thinking about a patient, I want to think about whether the local disease is under control, right? And there's no systemic disease, because those patients are not going to do well, and there's no reason for me to do a metastectomy, right? And the other thing is, I'm thinking about, am I going to completely remove this lung nodule with R0 resection? And is the patient going to tolerate it? Not just that operation, but subsequent operation. Because I know I've done this long enough where I do a resection, and there's more than likely that a patient will come back in the future for additional lung resection. So then it's not good for me to do a full lobectomy on a tiny 1 or 2 millimeter lung nodule. So my job is not only remove the lung nodule, but also preserve the lung as much as possible so that patient could then have a freedom to undergo additional treatment or could tolerate a systemic treatment. And then last thing I'm thinking about is there actually a better systemic treatment the patient's going to get that's going to eradicate that tumor? If there isn't, then I'm going to consider surgery, right? So those are the things that I'm thinking about. So if I have a patient who comes in for oligometastatic disease, single, very peripheral lung nodule, of course, I'm going to go operate on that patient with a minimally VAS or robotic operation. Patient get a simple wedge resection, go home. Minimal morbidity mortality. In my career, I never, and not just for this, but for lung cancer operation, for a simple wedge resection, mortality should be near zero as possible, right? And then, yes, there's a thoracoscopic pain, but then again, and some people do have a chronic pain syndrome. And I do agree with you that we should have some sort of quality of a life measure, but these are not your old operations where you're doing a full thoracotomy and patients in excruciating pain for up to 25% of the patient. What if there's a patient with a multiple lung nodule? Now, a place like in our institution where we have the ability to isolate and localize this lung nodule using a very fancy robotic technology, we were able to then go after very peripheral, even up to 3 millimeter lung nodule at a time. So frequently, I would say to Seth, yes, sure, I could go resect it. Because these are not, we're not taking a lot of lung for this patient with a chance of a fairly low morbidity and mortality. But what if you have a patient with a many lung nodule with a deep lung, especially with a deep lung nodule? Those are the patients that I think about because, yes, of course, technically I could remove those lung nodules, right? But then again, patients are going to have poor quality of life because they're going to be short of breath. They may not be able to tolerate a systemic treatment. Those are the patients, then I would say, try for systemic treatment, right? And see what happens. Is there, and some of these nodules will respond, but there are those nodules that develop a resistance, and there are patients with these nodules who will develop resistance, and they'll grow through it and then become threatening. Those are the lung nodules that I tend to isolate and remove, right? So not everybody the same. We have to be judicious about how we deploy the surgical arm of treatment for these patients, but yet surgery is not a boogeyman in this treatment paradigm. Thank you.
All right, great panel. This is perfect, and I think what I'm going to try to do here in my couple of minutes is just to show you how we can still screw it up so badly, despite our best intentions. So, okay, so note that my colleagues have presented timelines on the order of years, and we were hoping for that for our patient, but unfortunately we don't see this. So, 70-year-old gentleman. Great shape, golfer, going to the Denver Nuggets games all the time, left humerus lesion. And when we took this out, we actually found that he had this weird high-grade pleomorphic rhabdo-looking thing arising in bone. But as we do at our institution, if it's in the bone, we tend to treat according to osteoparadigms. And so he wound up getting neoadjuvant and then adjuvant dox cisplatin, changed to dox carbo for some renal toxicity. Completed everything in November 2021. And so by 7 months after that, he wound up having a solitary left lung lesion. You can see that there on the scan. Biopsy confirmed recurrence, no other Mets. And so we sent him to resection with our thoracic surgery colleagues. September 2022, we thought we were in great shape. First scan post-op, so 3 months later, new lesion, not previously present, or it was one of those teeny tiny little indeterminate things on the other side. Now we're at 3 centimeters. Didn't have any other Mets. We were like, well, do we really take a 70-year-old to a bilateral surgical resection in this quick tempo of progression? And so we opted to do stereotactic to this one in January of 2023. This guy goes and gets the most whopping case of radiation pneumonitis anybody's ever seen, and he was literally on and off steroids with oxygen requirements, not able to golf, doing his thing from February to September of that year. And all the time, we just wanted to get him back on systemic therapy. So we gave him some pazopanib, we gave him some Gemtex. Note that this histology does not lend itself very well to great systemic therapy options. So then, after that, he wound up having, again, another progression after the chemotherapy. So now we're in May of 2024. So he had this crazy radiation pneumonitis, so we didn't want to radiate this again, but he didn't really have systemic disease at that point. So we got fooled for a third time, and we said, all right, let's do surgery. Of course, there was a delay, right? So this was in May. We saw this lesion here. He needed to go on a trip. The OR schedule was packed, et cetera, et cetera. And so my surgeon texted me from the OR with this photo now showing that what looked to be fairly surmountable was this massive, disgusting-looking tumor. And obviously we did not do anything, but we've now taken him into a vat. We've monkeyed around with the whole environment. The guy developed a complex effusion, his lung exploded, progressive hypoxic respiratory failure, and died 4 months later. So what have we learned from all of this? We hear this from our patients quite a bit. Like, I'm scared about having a biopsy or surgery because what if it stirs up the tumor? What if it causes it to spread? And I'm sure I'm not the only one with a case where we've thought we had it under control. We go into surgery and then it comes out and it seems to have developed this ability to have wildfire behavior. And so I don't have time to go through all the details of this today, but I will point out my colleague Luke Selby, who's a surgeonc at University of Kansas, who's done a very detailed review about some of the factors that happen in the setting of surgery, and maybe this is not a surprise to the surgeons in this room, but there are clear biological pathways that get stressed in the post-op period. In addition to the theoretical mechanical knocking things loose, if you will, every immune suppressive pathway, wound healing, VEGF, everything you could imagine gets turned up in that immediate post-op period. And so is this a reason to explain why some of these patients have this sort of rip-roaring disaster course afterwards? I mean, even the anesthesia seems to impact this. So I would just encourage you guys to take a look at this. But so my food for thought here, what we hear is not all the sarcomas are the same, right? Osteosarcoma with multiple sites of disease that's got an intensive chemotherapy control plan is not the same thing as a high-grade adult sarcoma that you might barely have some marginal control without great systemic therapies. You want to control the biology. I have learned from this case as well as others, always reimage right before you're going in just to make sure you're not surprised if you can. I strongly reconsider in the setting of anything pleural. I feel like the pleura is not parenchyma, and it's really just has a very different course when you're just talking about oligometastatic course, more likely to have effusions and other such badness because there's just no walls in that space. Immunosuppression and healing post-op before you can initiate chemotherapy, put this into the big picture plan. Love the minimally invasive approach, to your point. And then I think what we need is really the trials comparing these different avenues. But also understand the biology. Why are they meting out to begin with? Are those pathways different in patients who do well with surgery or radiation, local therapy compared to systemic therapy? And then with what we've heard earlier today about radiation and immunotherapy, is there a role now for oligomets to not go in and try to cut this out, but maybe just addressing this locally with the benefit of the immune therapy to take advantage of that? So that's what I got.
Okay, with that, the floor is open for discussion, for burning questions, comments, suggestions. While people are coming up to the mic, in light of trying to gain some synthesis from the first session and the second session, I'm wondering what the panelists think about what Dr. Wilkie just suggested. In light of our success, perhaps not the standard of care, but certainly success with the strategy of using radiation and IT, is this something that we should be examining more deeply in metastatic disease? And anyone?
So, I know that, and then just besides the IT perspective, so, the question, a lot of things that were coming up is a local, we're talking about local therapy, both surgery, SBRT, and even a cryotherapy or ablative therapy. They're all local therapy. So the question is, when we're considering local therapy, what's the best option for the patient, right? And that's the kind of crux of all these questions. So when I'm thinking about this, so as I said, I'm thinking about lung preservation, because most likely patient will, just like your patient, will develop additional lung nodule when you do this. So then what is the best option for the patient? For me, the minimally invasive resection, surgical resection, probably is the best because, one, when you remove it, you remove it. We're not talking about radio resistance or any resistance whatsoever. I know that with a SBRT, up to 5 to 10% of patient nodules will develop a resistance and regrow in next 2 to 3 years. Surgery, remove it. That's one. And two, there's no additional issue with the radiation toxicity on these patients. And when you radiate a lung nodule, and I have to go back in there for additional resection, trying to do a lung sparing operation is going to be almost impossible. So for me, I'd rather just resect and then re-resect if I need to go down there, opposed to radiate, and then have to go re-resect because patient cannot get additional radiation treatment.
I think your point's well taken. And I suppose the fundamental thing for me is, would recruitment into such a trial be even feasible? Because this is such a dogma in terms of, well, you have to have an operation.
Yes, and I was kind of going to get to this. So then question is, how are we going to then design a trial? Because a problem, and this been, something like this been presented for a long time, and there's reason why there's no trial for something like this, because not sarcomas are all the same, right? There's what, 60 like various, histotype of the sarcoma we're talking about. And some of them are like something like osteosarcoma is very radio resistant. Ewing sarcoma is very, radiosensitive. So, and there's such a heterogeneous geneity in sarcoma we're talking about. And are we going to talk about trial for 1 lung nodule or 2 lung nodule, 3, 4? It's going to be very difficult to design a truly randomized trial. And so, to me, I don't think that's the right way to go. Having a multi-institutional registry kind of a study to extrapolate might be a sort of a better way to go for me. So,
Sir.
Yeah. Good afternoon. I'm Dr. Pratap from India. I'm a nuclear medicine consultant. Just it was a oligometastatic disease evaluation here. I just want to tell our experience on how we image these tumors. It is just not with the FDG PET scan will go ahead. What we realized by doing the FAPI PET scan, in case of sarcomas, we are able to detect very small lesions in the lung, which we were missed out in FDG PET scan. Therefore, before we going and telling it's an oligometastatic disease, better to go ahead and do the advanced scan like FAPI PET, which is a fibroblast activating protein inhibitor PET scan, which we regularly do. It is a very simple scan. It is a whole body PET scan. It takes around 15 minutes waiting time after injection. We do the entire whole body. No fasting required, no blood sugar control required. And it can be done with a gallium labeled gallium FAPI. And it can be done in-house. Therefore, what we do is we can do this PET scan even at night 9 o'clock. Therefore, in all these patients, what we standardize now these days is we don't miss out the FAPI PET scan. This is one thing. Second thing, coming to I want to share my experience with the FAPI therapy in case of sarcoma, where we treated one patient. He's a medical intern. He was my junior from the medical college. He came for the FAPI therapy. He had 2 lung lesions, which one was surgically removed. The other one was given radiation. I don't know the exact reason why it was planned so that. But after 6 months, he had a recurrence. He had developed 3 lesions, out of which, he was started on chemotherapy. Within the next 2 months, the lesions were increasing. That is, it was a progressive disease. And he came up, we did a FAPI scan. There was very good FAPI uptake. And lutetium FAPI therapy was given in a 2-monthly interval, 2 months. Then we noticed 2 lesions were stable. One was partially responding. Then he did very good for 6 months, then progressing. What we concluded by all this data is FAPI therapy targetedly delivers radiation to all micromats, whatever the lesions which were missed on FDG PET scan onto the tumor. The better tumors, the better clinical trials should evaluate the combination of lutetium FAPI therapy with immunotherapy or any standard of care to have better results. This is our opinion.
Thank you.
Oh, sorry. Go ahead.
Dr. Davis.
This is a question for the room, the panel, everybody. I have not implemented any kind of interventional radiology approaches like cryo or others, but I'm intrigued. Is that what you're going to ask? Yeah, I'm intrigued on the role and if anybody has experience when you might use it instead of SBRT or surgery.
So we actually asked for my patient about ablation for that last round, just given the issues. For ours, it was the location. So right by the heart, it was big, and they were like, we don't really feel great about trying to do this. But I do know that is something that's emerging, and there's some suggestion of like a pro-immune stimulatory effect in other types of cancer that are treated with ablation. So worth more looks. But any interventional radiologists or others experience?
I
think you just yell.
Oh, okay. Yeah. Yeah, we typically will consider, depending on the location, depending on what therapies that they need to get to, you know, because it's just a one-day procedure versus SBRT, which is like maybe like 5 every other day. So the other thing I want to kind of address what Dr. Kim had mentioned. Surgery obviously is a very great, good option for patients. I think with the radiation though, and the techniques that we employ, the local control rates are very, very good, 96%, at least in what we see in our literature. The other advantage is it can lead to some immunogenicity and upregulating the immune system and this abscopal effect we talk about. So I think that there is real advantage many times to use SBRT, but taking into factors that may increase the propensity for radiation-associated pneumonitis, we definitely need to take that into consideration. Fortunately, I haven't seen that much, but it does happen, and so we have to be thoughtful of that.
Just, I think we got time for 2 more quick questions, Dr. Rydell and Dr. Von Meeren.
More of a comment, just to follow up on Laura's statement regarding interventional radiology. We have a growing, albeit small, series with PEF or pulsed electrical field, which is sort of an emerging strategy as well. And at least in sarcoma, there has been some anecdotal reports of abscopal effects. So I think interventional radiology should have a seat at the table, at least for future conversations. Thanks.
I was going to say a similar thing. There's the Aaliyah procedure, which is really kind of electroporation. Patient with metastatic UPS who essentially had a very prolonged PR, including, you know, Mets by the heart, lung Mets. I mean, was treated in their primary. It was really pretty impressive. So didn't work so well the second time around, though.
Yeah, I agree.
Okay, so I want to thank everybody, thank the panel, thank the audience. I guess some takeaways as I think about it very quickly, some things that I learned. Not all lung Mets are created equal. Location matters, size matters. We suffer again from heterogeneity. Not all sarcomas are created equal. If there were one thing that just worked all the time, would obviously be doing that. I think there is some appetite to study this in a more thoughtful way and perhaps coming up with some harmonized data fields that we can all mostly get behind. It would be smart. The idea of RT and immunotherapy continues to be fascinating. And gosh, any suggestions of how we can do a better job with this, I would love to hear them. Thank you all very much.